Good afternoon, everyone here at the WEDI National Conference in Washington, D.C. Thank you for joining us. And to those of you online, good afternoon and good morning. Today, we are joined by WEDI member organization Madaket Health, who will be presenting the session, Meeting No Surprises Act Provided Data Requirements, Health Payment System Strategy, and the Role of Madaket PDX. Joining us to share insights and guidance into compliance with the No Surprises Act is the leadership team from Madaket Health, Eric Demers, CEO, Ted Acthem, co-founder and chief product officer, Martin Cody, SVP of sales, and Brian Marsella, president of Health Payment Systems. With that, Martin, over to you, sir.
Thank you, Bill, and welcome everyone online. I'm just going to make a couple comments with regards to what I've seen over the last 48 hours with regards to the subject matter experts that are all in this room. I don't know how anybody's doing all this in 1,440 minutes a day because the amount of data that's being required to monitor, troubleshoot, cleanse, pass, interchange, talk to, interface, fire, API, it's mind-boggling. The fundamental thing that I heard throughout the breakouts starting on Monday is everything is predicated upon a single source of truth and really accurate, clear, concise, fresh provider data. We focus on way far upstream from some of the things that we're talking about with claims adjudication and prior auths, but when you think about it, they're all byproducts of accurate provider data. And it's garbage in, garbage out, and it flows all the way downstream. So keep that in mind, and it's interesting because hearing this in DC this week, it echoes what I just heard last month in Las Vegas at HLTH. Huge, giant technology conference, everyone said, we can't do it without accurate provider data. So who has accurate provider data? And we'd like to think that we have the freshest current data, and now we're gonna be using that leverage of technology, sophistication, and usability to help providers, payers, and health systems comply with the provider data requirements of NSA. You know, we aren't gonna solve the IDR process, we aren't gonna solve the AOEB process, but as far as the provider data requirements, we can certainly help you solve those very, very fast and very efficiently so that you can focus on all of the other things that we're talking about here that require a significant investment of time. So I'm gonna introduce these guys, or actually let them talk to you about who they are. So first and foremost, I'd like to introduce Eric Demers, CEO of Madaket Health.
Thanks, Martin. Nice to meet everyone today. Thanks for having us here down in DC. Been at Madaket Health for 3 years, leading our journey forward. As Martin mentioned, we focus on really everything prior to the physician engaging with the insurance companies to provide care to patients. It's probably the simplest way to say it. We help them through all those processes to be in business together, all the administrative workflows. Our platforms automate that process between the providers and the payers. That's usually a very laborious and manual task on behalf of them. On average, a provider works with 20 to 25 different payer organizations in the country, so you can imagine the amount of churn that they incur. But through all the years of us doing that, we've now worked with about 80% of all provider organizations in the United States. So we've accumulated quite a bit of information that's very useful in how we go about our business. And that information is what helps empower the work we do underneath the hood around the data side of the business that we'll be talking about today.
Hi, everyone. Brian Marsella. I felt like a little bit of a fish out of water at this conference because nobody in my life would call me technologically savvy. My wife would certainly say I don't do anything standardly. I have a tie on, and I'm sure none of you have heard of my company. But hopefully I can share a little bit that will be helpful to you. I've been in the industry for over 30 years, mostly on the large carrier and consulting side. I've also been the board chair at FQHC, so I've seen a lot of this churn in the industry from a lot of different directions. I've now become, for about a past year, I've been the president of HPS, which is a very small PPO network in the Wisconsin marketplace. We actually mainly focus on the eastern border of Wisconsin, compete very favorably with any network that can be rented so that third-party administrators can utilize us to sell to self-funded employers. We actually were started for a different reason than to be a traditional PPO network. We were started as the entity that wanted to simplify the healthcare system for patients. So, you know, if you go get a surgery, you might get 5 different bills, and you're going to get them 4 to 5 times from the providers. You're going to get 5 EOBs. You have to try and match them up. You're not really sure who to pay, how to pay, or when you owe it. We've built a single explanation of benefit billing system that you get something that looks more like a credit card statement. So we've really simplified things for the patient. We also realized that as high deductible plans were increasing, that became a shift to the providers and to the members. The providers are now spending more money to collect less. And so we built a system where we pay the provider both the employer and the employee portion of the bill. And that's allowed us to have really strong relationships with these providers, really strong NPS of 75 compared to the industry norm of below 25. We've really had a really good experience. So we're now looking to take that outside of Wisconsin, and we're looking to continue the financing and the simplification. We don't want to own other networks, in large part because of all the work that needs to be done, things we'll talk about today. We will want to partner with existing networks and take the financing and simplification external to Wisconsin.
And I know you mentioned you've been in the industry a long time. Prior to HPS, what were some of the national carriers you were with?
Yeah, so I was with Cigna and Aetna for about 28 years. I was with Mercer Consulting, and then FQHC in Chicago that it's about 90,000 patients, so kind of mid-sized group.
And it's also fun for us to come to this conference because obviously with the pandemic, we didn't get to do a lot of things in person, but it's great to see some of our customers here. We're a little bit like Brian's company, HPS. Many of you may not have ever heard of us. We're kind of the Intel inside. PNC Bank is a customer, TriZetto is a customer, Novalon is a customer, and they're all here. But inside, we're routing a lot of the provider data to the appropriate endpoints and then bringing it back in. And as it relates to no surprises, that's precisely what's going to be required. And I'm curious, as a show of hands, this, by the way, you did not know it. It didn't say it in the disclaimer. This is the aerobics portion of the WEDI conference. So by show of hands, has anybody ever heard of Atul Gawande? Oh. Anybody in the Northeast? This is the New England board right here. Everyone here is from the Boston area. Atul Gawande has written 2 books. He's a surgeon at Brigham's. And his first book, or not his first book, but the first one I read was called The Checklist Manifesto. And it's interesting from the AI perspective that we just witnessed with regards to how much of AI is still built upon if-then algorithms. And it's very similar to what the NSA is requiring. You know, if this provider hasn't had an update in 90 days, we want to know about it. If this person has sent in, I'm at a new office location, you need to update your directory. The challenge is doing that and receiving that information at scale. His book, The Checklist Manifesto, if you haven't read it, I would encourage you to read it. But if anybody flew here today and you got here safely, because obviously I can see you, you have that book likely to thank for it, because it talks about all of the checklists that pilots have to go through as it relates to before you can even push back. Similarly, the 5 rights of medication administration, you know, right arm, right patient, right doses, right weight, all of that stuff, byproduct of the Checklist Manifesto. He came out with another book called Being Mortal in 2014, which I found fascinating because it talks about end-of-life decisions in a clinical environment. And if you were to apply those decisions that a patient has to make or a patient's family has to make based upon what medicine wants to do versus what's in the best interest of the patient, you know, this treatment is brand new. It has a less than 1% efficacy. It's a new cocktail of 3 drugs. And they're encouraging patients to try this. It's like, well, maybe the end-of-life decision they should make is the cocktail of a martini. That would be more gratifying to them than a mixture of drugs. But he really brings a holistic approach to it, which is kind of what we try to do at Madaket. We look at what each individual prospect is going through as it relates to gathering your data. And I will tell you, there hasn't been a single company yet that hasn't been kind of a little bit embarrassed with the quality of their data. So, and Brian may share a little bit of that this afternoon, because don't be afraid. We've heard it before. Ted and product has seen it before, but that's what we're all here, is to get that data clean and accurate so you can start participating more effortlessly in some of these downstream things that we're all looking at today. So, more aerobics. NSA requirements. Who can tell me what you have to do within the first 24 hours of receiving a provider data change, according to the No Surprises Act? You also did know this is going to be linked to payroll deduction. Your organizations have authorized that if no one knows it. You have to acknowledge as a healthcare organization or a payer that you've received that update of provider data within 24 hours of it being sent. That is a red alarm for a lot of organizations, because they don't They don't know that they have to do this, number one, but think about your organization, how you're receiving information. It's coming in sometimes via rosters. It's sometimes coming in via Salesforce instances. It's sometimes coming in via Jira tickets, via fax, via text, via email. How are you supposed to notify that provider organization that, yes, we received your information? Who knows what you have to do within 48 hours? Are there any payers in the room? Okay. What do you have to do with that received data within 48 hours? Correct. You've got to update your member-facing directory within 48 hours of that new information. And this is where we talk about member scores, patient and member experience, and the amount of incorrect data that is in member-facing directories is off the charts. And this is where a patient will tell you their grievance that says, hey, it says on your website that you're seeing new patients. Oh, the website's wrong. Or it says that you're in my network. Oh, that's wrong as well. And so now that member experience has just gone downhill at a light speed pace. And last but not least, who can tell me what you have to do within 90 days? There's going to be fines on this very soon, not from us, but CMS is salivating at this. You have to attest that your provider your provider directories are up to date. Now, we've talked about attestation, or there's been discussion about attestation this week in a lot of the different breakouts. One thing that wasn't discussed is true or false. Attestation means accurate. False. Whew. There was a 50-50 chance you all did well. Correct. But you have to attest every 90 days that you've looked at this data, that this data is what you've received, that your directory is up to date. Doesn't mean your directory is accurate. And the same downstream member bad experiences can happen, where if you've got Dr. Cody who has 5 practice locations for pediatrics, and I've stopped seeing patients at one of the locations, but I haven't updated our directory, and that's still showing on the website of that pediatric practice or the directory for the payer, that's a bad outcome. And that's the sort of stuff that CMS is going to start fining on. Now, it remains to be seen when they are going to start fining again, because they started, but then everyone was in an uproar because they said there's no way we can comply with this. We don't have the bandwidth, we don't have the rails, we don't have the staff. And it was one of the questions that I asked on the WOVA app with regards to when do you think CMS will start initiating fines or renew the fines? Because we hear it all the time in the industry, I'm not doing anything until the penalties come. I don't have the time, I don't have the staff. When they start fining people, then we'll get our ship in order. That might have been a mixed metaphor, house in order. So 55% of the respondents of that survey said they don't think CMS is going to do any penalty initiation in 2024. So this is another whole year potentially of no stick to cause any type of action. But the payers that are taking action now will be well ahead of everybody else because this is fairly easy from a Madaket perspective on what we do with provider data because it's all we do. And we've been doing it for over 12 years. So we'll get into the weeds now that you know what the requirements are, but think about it. This is, Eric said, this is everything that happens prior to the provider seeing a patient. So NSA compliance and organizational needs through the HPS lens, and Brian reached out to me over a year ago and said, we need your organization to help us because our provider data is filling your own expletive. It was not pretty. So Brian, I'll let you talk a little bit about kind of what you experienced when you came on board. Ooh.
Yeah, so as I came on board, I actually had a little overlap with the prior president, which is kind of good to be able to do that. And he left me a listing of what he called big rocks. And under big rocks was compliance with NSA. And he said, yeah, we haven't done a lot with it. He said, we used to take weeks, if not months, sometimes to update things. We've improved that to somewhere in the, doing it within a week, but we haven't really, complied with the 2-day turnaround by any means. So I attacked that, and we actually took our staff and figured out how to deploy them to make sure that happened. We only have 100 hospitals. We've got 27,000 providers, and we've got about 700 contracts. So we're not large, and we'd only do commercial. But the fact that I had to have 2.5 people that were always on call to be able to do this will give you a sense, I think, what some of the other organizations that are larger are going to be dealing with. So we solved that, and I'm very confident we're meeting the 2-day turnaround time from that perspective. I then actually was doing an addendum process, and can't tell you how many times we got something back from the providers. We used DocuSign to send it out and said our name is off by slightly, or we now have a different address. And that made me really understand that we've got a lot of issues to do. I then actually had a financial hit come in. We had a hospital listed as having an urgent care and an emergency care at the same location, where they really only had emergency care. So guess what? Somebody went in, they went there and expected they were going to have it adjudicated as an urgent care versus emergency. I believe in stepping up when you've made a mistake. So we actually paid the differential between the urgent and care. That's when I said we've got to get serious and figure out how do we do this. Of our 700 contracts, about 20 of them come in as roster files, and we weren't even automatically uploading those technologically. We were manually adjudicating those. So I couldn't even, if they were pre-attesting to things, I couldn't even say for sure that we put them in the directory properly. And then all of the other contracts, and that accounted for almost 70% of our changes that would have to be made. The other 30% come in through 680 different ways, as Martin was saying. We get some in email, we get some via phone call, we get some through a Zendesk ticket. It's all over the place, and there's just no way with our technological system where we're trying to ramp that up to be able to do more payment outside of Wisconsin so that we can pay providers, both the employer and the employee portion, as I mentioned earlier. We just couldn't do this internally. And, I have so many other needs within the organization of where to use our people and use our resources. So we did an RFP, and we looked at about 5 or 6 different entities, and we found that Madaket was going to be able to really do the most for us up front in actually helping us take these disparate ways that we were getting information and be able to pull that all together. I was a bit embarrassed to look at our portal, our website that had the network in it. And so we wanted to upgrade that significantly. And that's part of what we'll be doing with Madaket as well, as the source of data. They will also now be able to make sure we're upgrading that website experience to be visually better, but also have more information that can be actionable by a member when they're trying to make a decision on what provider to even go to in the first place. So we are just getting it kicked off. It quite frankly took us a long time to make sure we knew exactly what we were doing, to maybe figure out what we needed to have done. And then we had some great conversations about, well, why you don't need to do it that way. Here's a better approach. And it's been an incredibly consultative back and forth discussion with the folks at Madaket. And I think we'll be able to clean up our data very quickly, make sure it's displayed in a more visual manner, and they'll be able to help us scale nationally as we go to build our patient financing network externally.
And I'd encourage everyone to kind of look at your own member-facing directory, if that's something that you have, and view it from the eyes of a patient, and see how easy it is from a GUI, a UX experience, to schedule a visit at a provider that is accepting new patients during the accurate office hours in the plan that you want to participate in. Chances are it's not as easy as you hope, would want. I've heard it on a number of regulatory calls here with WEDI and the provider sub-work group, where the payers are saying, I have the app on my phone for our insurance plan, and it says in our own plan that provider's in network. And then we go to that office, and the provider's not in network. And I work for the company. So most patients don't work for large carriers from that standpoint. So view it from the patient's experience, because what Brian's identifying was with their network and the experiences people were having both internally and externally is not isolated. We hear it all the time. And that's the part that is actually going to then feed the GFEs, the price transparency, because you have to make certain that provider is who they are, practicing where they are, in which networks you can actually effective a good faith estimate in that capacity. Anybody ever experienced that from a patient perspective? With regards to nodding, smiles, and laughter, it's never fun. And we're in the industry, so I can't imagine what John and Jane Q Public have to endure. I do want to talk at technology at scale. Anything with this monitor over here?
It was on his face, that's why
Oh, okay.
The
No.
glare is amazing, though, so maybe leave it on.
All right, so Ted Acthem is co-founder of Madaket and also oversees product, and so he'll talk a little bit about, and I loved all those questions from the last session, how he envisions this philosophically in going to market with regards to helping you all scale from an NSA standpoint.
Great. Thanks, Martin. Before I hop into the solution that we've crafted and that we're rolling out with HPS, I wanted to give a bit of a background as to how we think about building product, how we think about use cases and our approach. And it's really twofold, or there's really two work streams. And the first one is more the macro view, the industry view, right? Is this a problem we're solving? What's the impact of this problem? What are the industry organizations saying and feeling, right? So WEDI is a great indicator of that. What's the trend here? And at the same time, we then bounce down to a very much lower level, grassroots level, and we look at who are some thought leaders, who are some lighthouse clients that we can engage with to see the details of how to actually go and build this, right? This allows us to iterate very quickly, right? We can build software very fast, right? But we need to get into market. We need to get users using it. When we do requirements, when we talk about the ins and outs of how something needs to work, the details escape people, right? We don't always have, classic waterfall methodology we know does not work because we just can't predict everything up front. So getting into those details early on gives us a way to move forward even more quickly and get to a better endpoint quickly. So there's a sort of bifurcation between the macro and the grassroots. And so this is a philosophy we've had from a product perspective at Madaket since our inception about 10 years ago, and we are pulling that forward now as we are launching with HPS and looking to bring our PDX platform really to address data intake and provider directories. So that's philosophy. Let me talk about the solution at a high level. So 4 key modules that I want to call out today that really comprise the bones of what we're doing. The first one's around data ingestion. So as you all know, and as Brian called out, currently, data is being communicated, provider organization data is being communicated in a whole host of formats, largely in the Excel world, but within there, structurally all over the map. It also comes in via fax, which gets converted into emails. It comes in just in the body of emails. So we have a platform, our data ingestion module can handle any of those different types of formats. So philosophically here, what we wanted to do is make sure that there was no barrier to sending us data, and we are doing the heavy lifting in converting that data and being able to ingest it. We take that and put it into a common sort of internal representation so that we can process it, right? So second module is really on processing, right? This is data curation. So we take all the data that's coming in and we score that data. So different sources of data have different levels of quality, and that's a very important attribute for us from the perspective of being able to determine what is the most recent or the highest quality data. And it's really quality accuracy that we're after. There's a correlation with recency, but not always. And as we start to expand the breadth of the data that we're ingesting, right? We, as part of our broader platform, outside of just HPS, we do, as Eric mentioned, we have to do a lot of transactions through our system. There's a lot of provider and organizational data coming in, and this is all transactional data that's being done on our system. So audit history and all that good stuff is sort of part of this module, and the output at this point can be used to power a public provider search directory, right? So we are going to stand up a new modern interface for HPS, but the actual value there, which is the curated data, that is coming out of this data curation module. Module 3, this is really around analysis, right? Look at KPIs, look at reporting. Martin's slide earlier around the 24, 48, and 90 days, right? Those are key performance indicators that we need to hit. So we want to be tracking them, as well as from an HPS perspective, we want to give sufficient visibility so that they can see what's going on. But this is all at the analysis level, right? There's too much data under the hood. There's no way you can inspect it visually. What happens if one of those
You're getting further away.
one of those performance indicators does not meet expectations? And that's really our fourth module, and that's around data integrity and data completeness. So here is where we leverage Madaket's sort of experience around reaching out to the community, so reaching out to provider organizations, providers, other intermediaries to complete the data to track down the missing data in order to hit the 90-day compliance, the 48-hour compliance, and so on and so forth. So there's a component there as well that historically in directories from an attestation or verification perspective, yes, there has been an attempt to handle sort of inbound data updates, but there are also lots of providers out there that have not been interacted with, touched in 2 years, 3 years. Now, the data may still be accurate, but from an NSA perspective, we need to be able to verify that. So from an overall solution completeness perspective, that is also a critical component to fold in and report on and show analysis.
And it also introduces, just to interject, not only is there data accuracy components from analysis, but for Brian's group, it introduces, bless you, for Brian's group, it introduces some business use cases as well. Well, if we haven't heard from a provider in 75 days, and they're bumping up against that 90-day mark, what do we do as an organization? And then determining what are our outreaches. Is it 3 calls, an email, and then someone runs by the office to see if they're still alive? I mean, what is the use case for that? So do you have, Brian, some thoughts on some of the conversations that your group experienced in this whole process?
Yeah, I think that, we know we need to get closer to our providers, so this will be good. We didn't have any way of tracking when it was the last interaction with these providers by any means. Small staff. Again, we're under 50 employees overall. The other thing that's interesting about the NSA requirements is it doesn't actually say you have to pull them out of the directory after 90 days, right? There's still a lot of gray areas to exactly what you do, but we'll be needing to make business decisions on do we pull them out, but we could keep them in network if somebody happened to bump up against them. Do we wait 180 days? Do we go through the process? So there's still a little things that we have to go through and make sure we understand. But that's the kind of thing that'll be helpful to us. It might trigger me to make sure I have my provider relations team make an outreach. It might trigger to me to send out an addendum and try and find if we can get some engagement. So there's going to be all kinds of different ways that we'll use it. We are looking, to Madaket to really do the attestation and help keep us compliant, because that's a big piece of what we're not going to be able to do. But we have to. We ultimately own the relationship. We need to make sure that we're folding those two things together: the compliance and the fact that we want to make sure we have providers that enjoy being part of our network, that are treating our members properly, et cetera.
Well, what's interesting in that conversation as well is that this rule is actually driving some of that provider conversation that hasn't really happened much at scale in the past, right? So if you think of those large directories, especially in the large payer organizations that we've been involved with, those conversations, when do you take someone out of the directory? How do you know that their location has changed if they haven't updated it? And then if you start to take on risk-based plans and some other stuff with your providers and you're assigning members out by zip codes or the different providers that you believe are part of those organizations that you are working with, and you fall through that process, and then you kind of find out 6 months later that, oh, by the way, they haven't worked here in a year and a half, and there's now a whole gap in that process. We see that quite often, and that leads to a lot of challenges both on all 3 sides, right? From a payment perspective, from a revenue leakage perspective on the provider side, and then from the member experience as they go through that process as well.
Yeah, the other thing is adding a provider. And all of the groups that we went through the RFP process, none of them were really going to be able to share with us that if a provider was added, they were just going to analyze what we had in the system and was it accurate. And that was one of the things we really liked about Madaket, is they would be sharing with us, look, we see that there's a new provider at this entity. And I think we're going to start seeing a pendulum of a lot of providers going back to trying to be independent. there was a huge, groundswell of them going to work for the hospitals. I think you'll start to see that going back the other way. We definitely are seeing it in Wisconsin. And that's going to be, they're going to go away from being in a roster file, and they're going to go to being one of those one-offs, and we may need the interaction even more at that point.
And it's interesting, Eric and Brian talked about adding a provider. We recently did kind of an adjacent project with a large clearinghouse that was curious if they could link NPI number to the appropriate fax number at the office. And they sent us a test case of 100 NPIs, and could we find the fax number so that they could correlate the two? And lo and behold, in doing that work, smiling, it wasn't you, smiling. Lo and behold, in doing that work, we would get in touch with the office via automated outreach and finally drill down to who we need to do that. Like, yep, the fax number is correct, but that provider is no longer here, hasn't practiced here in 2 years. So their data at the clearinghouse level was all, from its standpoint, it lacked the accuracy that they required. And when you think about the manual processes that an office administrator has engaged in over the years, that they'll just check 25 boxes on these plans that says, here's my address, here's the 5 locations that we're seeing patients. But when one of those locations changes, they aren't going back and updating 25 plans. So those 25 plans are sharing that information, and they're just sharing bad information because it's not accurate, it's not pristine, it's not a single source of truth. So that's what we're trying to solve here. So we wanted to invite a couple groups, and I'll let Eric, if he wants to chime in, because right now we've got HPS that took the lead and wanted to jump in, but we have one data point. So what we want to do with WEDI is showcase some successes at the spring conference to say, hey, we can have you compliant with NSA around provider data in 120 days, and you will never have to worry about it again. But we would love to have, I see a smile, that would be good, wouldn't it? Smiling with regards to provider data accuracy. So we wanted to incent you. We don't have grants, because CMS was talking about maybe we need to do grants to force behavior. The penalties we all know are coming, so we'd be curious if there's anybody that's interested in solving some of the provider data and also then opening up for questions.
We have an online question.
Sure. Do you need a mic?
Sorry. Do you facilitate other provider communication support between payer and provider?
So yes, we do. So other communications from a platform perspective, our system, we do EDI, ERA enrollment, we do payer enrollment. PDX platform is around broadly roster management and directory. So we have our platform facilitates all types of communications from an administration perspective between providers and payers.
Yeah, just to expand on that too, through that process of all the years of doing all those enrollments and everything else, it also allows, organizations to facilitate, credentialing processes and licensing and CME management, other things out of that we'll partner and plug that in so they can manage it in one place. But the rails have been built with a lot of the payer in the country in order to allow to facilitate that back and forth communication between the platform providers and the payers directly inside that platform. So they don't have to go around to manage that. And then they can, when you get through the end, they can, and it's complete, you can do all the electronic signatures in the platform, et cetera.
Good question. Anyone else? I don't want to get in the way of lunch. Sam, anything online?
That was the only one online so far.
Okay. Then I think that would be the adjournment. So thank you all for attending. Appreciate the opportunity and look forward to interacting with you either at lunch or throughout the day. Thank you.
Thank you.